Let me share the screen now. Now that we are going to go live, I'll open the screen.
I'm not able to see Dr. Bala.
Uh,
Dr. Bala is not seen.
I'm
can see
here.
him.
Sir,
I can
please
see
start.
yeah, Dr. Bala is there. Fine. So, Prem or Gaurav, you tell me when you want me to go, when you want to start.
Just a minute. Brijesh?
Sir, please start. It's go ahead.
Okay. So, very good afternoon, viewers. Welcome to this webinar in this COVID season. And I'm sure you all are enjoying this virtual CMEs and seminars sitting at home without exposing yourself to the risk of the deadly coronavirus. Friends, medicine is science, but practicing medicine is an art. I still remember 2 years ago when I started my pediatric practice, a couple walked in my clinic and the question that they raised really baffled was, "Ab ka sir garam lagta hai." Something that the child's forehead was warm. If I start reading question or answer to this question, the in our forefar that we used to read in those days. And I'm sure, friends, such questions that we face in our day-to-day practice, and what is wisdom? And we would, all of us, that wisdom was with experience on the background of knowledge. And we have lot many questions where you really don't have straightforward answers found in any textbook. And to answer these questions, we have a panel of experts, very experienced, knowledgeable, from all over the country. Let me introduce them to you. We have Dr. Shyam, who is heading the pediatric department at the Max Hospital, New Delhi. Then we have Dr. Bala Subramaniam from the director of the Kanchakamakoti Child Trust Hospital, one of the most and most sought after teachers all over the country. Then we have equally well experienced and equally passionate Dr. Baldev Prajapati from joining us. And then finally, we have Dr. Jaideep Chaudhary, who is an astute clinician, a very gentleman and a close friend of mine, joining me on this panel. So what I should do is raise some questions that all of us face in practice, and this to the pearls of wisdom, so that in faced with these kinds of questions in our practice. So let us start with the first question that I was baffled by. One of my first question in my practice: Doctor, my child's forehead is always warm. Sir, ya matha garam. Sir, you must be coming across such questions very often. So, Shyam Kukareja to open the innings to answer such patients.
See, this is quite common that mother comes and tells, sir, isko hamesha matha garam rehta hai. What is the reason for this? And this usually happens in children, and I think up to the age of 2-3 years, when the forehead is a little warmer. I think it's more to do with the large surface area proportionately as compared to adults, to a lot of blood circulation. And third, maybe it is a lesser fat in the scalp. So all those factors combine, and that leads to little warmer head. And then in our culture, there's a tendency of overwrapping the child in all weathers. The mother has a fear कि ठंड selectively बच्चों को ढूंढ रही है. And that's the reason I think many of the times they are overwrapped also. So all those factors combined make the head little warmer. But I have to see sometimes a infection may be starting and the head is warmer. So I have to be careful that it's not a onset of infection. In that situation, take a armpit temperature, and the armpit temperature will better correlate with the core temperature as compared to the forehead temperature. And you can make out or the child is active, playful, comfortable, and he has no other issues. So all these situations combined feel that this child, the mother should not worry about. Is a break in the link? Yes.
I'm sorry, I lost connection from my end, and I'm
Mm.
sure Dr. Sham, I could hear Dr. Sham answering this question. So now again, coming back to the question set, another common problem that is asked to us by many parents is I had a mother coming the other day to my clinic saying, Dr. Saab, my 5-year-old has a white hair in the scalp. Dr. Balasubramaniam, I'm sure you must also be getting such patients. How do you satisfy these parents? What answers do you give?
Thank you, Vijay. When a 5-year-old child comes with one white hair, it is very, very unlikely to be a symptom of serious local or systemic disease. That is number one. Majority may have 1 or 2 white hairs. If the child is otherwise well, we can reassure the mother and probably with a joke saying that your child is gaining wisdom in a very young age, and humorously reassure her that your child is okay. You don't have to do much about it. And perhaps question the number of gray hairs in the parents without upsetting them. That is number one. Two, one of the pieces of advice we should give when parents spot a single or a couple of white hairs in a young child is not to pluck those hairs. Dermatologists say that if you pluck such white hairs, the trauma generates nutritional injury to the surrounding hair. There are chances that many more gray hairs can occur. So we should tell the parent, don't do anything about it. Ignore it. But on the other hand, there are a few situations in which the white hair could be sinister. They are far uncommon. They are extremely, extremely uncommon, which could include common nutritional problem. Any child who has got any anemia, particularly pernicious anemia, is supposed to produce premature graying. But I have not come across any child presenting gray hair with pernicious anemia. That can be there. And hypothyroidism. And if you find multiple hairs, you have to look for lesions of vitiligo and some genetic syndromes, names of which we need not remember, may have white hair. And perhaps a few conditions which could manifest with white hair could be rare things like tinea capitis. So by and large, one white hair in a 5-year-old child, most of the time, I will reassure the parents, crack a joke and send them.
Okay, very well said. So there is a scientific basis of, behind concerns raised by many parents that, Doctor, if I pluck that single hair, is there a risk of the child getting more gray hair? And very beautifully explained by Dr. Bala here. So let us move on to the next question. My 9-month-old has a very sparse hair and has not grown much despite shaving his his scalp 2 months ago. And this is again a very, very common misconception that the parents have, that if I shave the scalp, there'll be ample hair regrown on the scalp. Jaideep, how do you address such parents?
Well, good afternoon. Now, sparse hair more often than not is normal. Usually, it's the hereditary what's there in the family. That's the commonest cause of sparse hair. Now, other causes may be some behavioral issues like trichotillomania, the plucking of the hairs, sometimes infection of the scalp like tinea capitis. Rarely, it may be due to a manifestation of Down syndrome or hypothyroidism. Generally, sparse hair, if the child is otherwise normal developmentally and on physical examination, it's not a cause of great concern, and it's a hereditary and it's a normal variation. Rarely, local infection and other systemic causes are still rare.
Okay, so sparse hair by and large is hereditary and to be left alone. Parents to be reassured that shaving the scalp is not really going to help much. I can see Sham raising his hand. Please come in, Sham.
Sparse hair at 9 months is a quite a common phenomenon. I always tell the mother the child had very good hair at the beginning. Then he started losing around the age of 4 5 months. And this is known as a Kudrat ne mundan kar diya, which is a natural mundan. Kudrat does this mundan. Okay. And then after that, and the child has a lesser hair up to a maybe 9, 10, 11 months. And the hairs start coming back after the age of 1 year. So this is quite a common phenomena in the babies, and we should not worry much. Agreed, as Dr. Jaideep said, you rule out if there's a tinea or there was a cradle cap or there was some infection there. I think you just rule out. But the sparse hair in an apparently healthy child who has no problems, which I think your question pertains to, in that situation, I'm not too much bothered, to be honest. I think we're not going to miss anemias and other things. We're not going to miss that. And I think this usual phenomena which happens in our practice in normal children is just physiological, and we should wait maybe around a year and then the hair come back.
Very well said. So viewers, please collecting these pearls like Kudrat ne kewa mundan. Yeah, Jaideep, you want to add something?
Yeah. I just missed the last part of your question. That's head shaving. Now, this misconception is there that shaving increases the hair density, but it's totally wrong, because the number of hair follicles is genetically determined, and shaving will not alter the number of follicles. Really.
Okay. Let us move on to the next question that I have framed is something where Dr. Son sweats a lot. The pillow that he uses gets wet due to sweating. I mean, many mothers come saying that, oh, रात को सुबह उठो तो pillow गीला रहता है. Dr. Baldev Prajapati, I'm sure you must be getting such complaints in the practice. How do you answer these parents?
Yes, I think you rightly say that this is a very common complaint from the parents. And I'm sure that if you are not aware of the basics, we may not be able to address it properly. All of us know that regarding this distribution of the sweat glands, it is very specifically more over the scalp and the neck. Second thing, even the numbers of the sweat glands is also more over this area. And third, even the physiological function gets mature over these glands earlier, around 4 5 months. I think these are the reasons that very specifically the excessive sweating is there. Another thing is known that whenever, already Dr. Sham was talking, that it is a common tradition in our country that babies kept overwrapped. And many a times, even in the months of heat also, the baby is overwrapped, and that's the reason that there should be some sweating so that the baby can get cool. And for that function, this excessive sweating is there. And if I remind you that due to the more of these sweat glands over the scalp, even the heat loss is also more possible at hypothermia in the newborn. And that's why we advise them to cover the head specifically, because all of us are aware that due to the more of the sweat glands, more of the loss of the heat is possible. So I think at the same time, particularly at the time the excessive sweating will be there. So I think very nicely we can explain them that excessive sweating is due to this reason, provided that baby is healthy and hearty. We'll have to exclude some of the causes for the excessive sweating. That is occasionally it can be in a case of the rickets or even due to some other reason. If it is not there, then I think by and large, healthy and hearty baby and having this complaint, probably we can explain them. And in the due course of time again, it disappears.
And sir, आपने explain कर दिया. I told my patients, and 2 days later, I had a patient walking in my clinic saying that उसके हाथ और पाँव हमेशा गीला रहते हैं.
Yeah.
And he sweats a lot on the palms and soles. Can you address this issue?
Again, then Dr. Vijay, it should not be the same patient of the same age.
Not same patient. It's a different thing.
That's what I'm telling you. The reason is, in the mature child or older child or even the adults, again, the distribution of the sweat glands is more over the soles and palms. Anatomical distribution, if you remember, I'm sure that we'll be able to answer. And therefore, whenever there is such condition that requires this cooling effect, then the excessive perspiration can be there. Okay, I think all of us know that in the at the time of exam or anxiety or the stress, the excessive perspiration can be there. There is different reason. We'll have to see that there is no hyperthyroidism in the older child or the adults, or even rare condition which I have come across the 2 children, that is pachydermo hyperostosis, where the skeletal system is also involved. And I've seen that when the child is walking, you can see the footprint over the floor, that perspiration, or the child cannot write. So, but these are the very rare conditions. But I think we should keep in mind that suppose nothing is there, thus we can explain. And if you find some very specific reason, I think we can treat that. But this is very common.
Thank you very much, sir, for beautifully explaining why there is excess sweating in the scalp and the hands and feet, palms and soles. And barring those rare conditions, if it is an isolated finding in otherwise healthy child, what is required is reassurance and the explanation. I can see Dr. Bala raising his hand. Yes, please.
I have seen quite a few young children having severe hyperhidrosis, interfering with their writing in the exams. That's something very disturbing. Their performance comes down, the stress increases the hyperhidrosis. I have tried 2 things. One is topical aluminum chloride is available. Trade name is topical. Is the lowest solution is available. You can apply. And if it is very severe, I have given a few children oxybutynin, what we use for voiding dysfunction, bowel bladder dysfunction. Propan. I have used it for exam going children because I don't have great references for it. But I at least the parents have come and told me children were able to write the exams better. This is one practical problem I have faced, and this is a solution I have offered to the parents.
Very true, very true. At the same time, one must not forget excessive sweating of the forehead in an infant who is sweating at the end of feeding session, who is breathless. Keep in mind an early impending failure. And Sham, you were raising your hand.
I think I wanted to raise the same point. I think it is small child less than 3-4 months. If the mother comes with the history that after feeding or during feeding, he becomes breathless and as well as sweats, I think this is a sign which is indicative of cardiac problem.
Jaideep, you wanted to make a point? Jaideep, you wanted to say something?
Yeah, actually, Dr. Bala has told most of the things that I wanted to tell. It's because sometimes it's the books get totally wet due to the sweat. So, and the extreme power.
Adsorb powder used to get candid powder, adsorb powder. How useful are these talcum powder preparations?
There are some actually the talcum powders, they only block the sweat pores. So that will not cure them. There are some antiperspirants, then anticholinergic, as sir has told, and rarely to that extent. Sometimes the dermatologists, they do the iontophoresis also to stop the excessive sweat.
So here we have addressed the issue of excess palms and soles. Now the question on my 2-year-old gets up crying in the middle of the night, cries for 15-20 minutes and goes back to sleep. And I'm sure Dr. Sham, you must have come across such parents. How do you answer then?
I think most of the time the child on examination is normal. There's no nasal block, and this is one thing. And then there's no adenoidal. It's little too early. And these are two things which can create the child to cry in the middle of night. Other thing can be if the child is given bottle feed at the time of sleeping, and he swallows a lot of air. Some aerophagy can also lead to disturbance in sleep. And if the tight clothes are there, all those factors, it's little more cold, more AC children have been subjected to because the parents are very comfortable with the 18-degree and all that. So this is another. So all those factors make the child cry. But if you have ruled out all these factors, that this is not the cause, then one of the common condition is that night terrors. And night terrors, the children just cry in the middle of night with no rhyme and reason. And they are not consolable, they are irritable. And you have to, this happens between the age of 2 to 5 years. Then you take them around, roam around and all that, I think 15, 20 minutes. And they're not responsive. Means if you're talking to them and explaining them, they are not responsive to that. And after 15, 20 minutes, they go back to sleep. And next
Absolutely
morning,
well
if a
said.
3-year-old child is there, you ask, if your 3-year-old child is there, if you ask in the morning, kya hua tha raat ko, he doesn't remember. So this has been categorized under non-rapid eye movement sleep disorders, as compared to rapid eye movement sleep disorders, where the nightmares come. So the child remembers next morning. Now there's, in my experience, I had one child who was little too much disturbed during the sleep. And after that, the parents are really worried. The episodes are lasting 30 minutes, 40 minutes. In fact, I investigated this child for temporal lobe epilepsy by admitting the child and doing a EEG. But everything was normal in that child. Didn't turn out to be a temporal lobe. Video EEG was normal. So this is one thing which a pediatrician should keep in mind: is it that or not? And this is what I described. This may be most likely a night terror.
Yeah, so very well, answered, Dr. Sham. We do children, I mean, parents are really hassled, both are working, and in the middle of the night, the child gets up, cries, the parents' sleep is disturbed, and they are really hassled. What age does a child start getting night terror or nightmares?
I think most is between the age of 2 to 5 years, I think, most.
Okay. So it can come as early as 2 years. So as he said, it is extremely important to rule out organic problems like adenoidal hypertrophy and other.
And there are other things maybe
people
disturbing the child, and
conditions,
you name it as night terror. That will be very, what should I say, not good for the child.
yeah. Okay. Now, lot of children, we get parents come and say that for no rhyme or reason, this one of the ways he throws tantrums, he keeps banging his head, and he also bangs his legs in the sleep. Jaideep, would you like to address this?
Yeah.
Head banging and banging the legs in the night.
No, banging the legs and sometimes the arms also. This is a typical of the periodic limb movement of sleep. That's commonly known as PLMS. Now, the children usually present with some twitching or jerky movements, and typically about a half a minute duration. But sometimes it may recur throughout the night also. So what's the cause of concern for these children may be that sometimes these are associated with a more serious conditions like the restless leg syndrome, which is typically a neurological sensory disorder. It's a sleep disorder also. And it may lead to the some daytime sleepiness, then it affects the mood also, concentration, the school performance. So if the child is not having such effects as daytime sleepiness, the child falls asleep during the daytime, refuses to get up in the morning, and it is not disturbing with his sleep, and it's sometimes just banging his legs, then falls asleep and rest, everything is normal, then we can reassure the parents. But if it's of such a severity, then definitely we have to think of these conditions. And of course, like the previous child, we have to rule out seizure disorder also if it's disturbing, if it's recurrent. Now, rarely it could be a part of a growing pain or also a dream sequence also in a child with a movement of the legs.
Okay. Yeah. Yeah, Jaideep, at this point, let me ask Dr. Balasubramaniam that many a times, I mean, one of the mothers said, I went to a pediatrician and he said, these are growing pains. कुछ नहीं करना आप पाव दबा के दो. So how do you address these issues? I mean, it's really bothersome. Some parents really complain that the child is unable to sleep in the night. He says there are leg cramps and he keeps banging. So, and he has uncontrolled. Dr. Balasubramanian?
Yeah, your audio is breaking. It's okay. Fine.
Can you hear me?
Yeah.
Yeah. So leg pains. The parents were said that these are.
Yeah. See, there are two or
it's really
three
bothersome. So how do you satisfy this?
Yeah. There are two or three important points we must remember before we address the concerns of the parents. One, we must remember nocturnal pain is always organic. It's not likely to be functional. It's not malingering. A child waking up with pain in the night is definitely something which cannot be ignored. That's one. Two, we must look for red flags. Three, by and large, most of the pains which occur between the age of 4 to 12 years is growing pain unless proven otherwise. And some characteristics of growth pain are worth remembering. We can actually get a good history from the parents. The history is like, basically it is a child ignorant children who spend a lot of time running around, exercising, playing. That's number one. Child is always well in the daytime. Two, the pain is not in the joints. It's around, away from the joints, usually in the thigh or calf or lower down. Next thing is, the child, once it gets up in the morning, it's absolutely well. And most parents worry about the family, some child would have had some leukemia or some bone malignancy, they'll be worrying. Usually this growing pain is bilateral, it's not unilateral. Unilateral is sinister, is usually bilateral. But what I do is to get a good history, do a good physical examination, and I have found that quite a few of these children who come with a lot of growing pains have what is called benign joint hypermobility syndrome. But I do what is called, I elicit signs of hypermobility, like showing how they can flex the thumbs, how they can hyperflex the fingers, how they can lock themselves with their hands. And I demonstrate genu recurvatum and reassure the parents, saying that your child's joints are very elastic, your child will do well in yoga or in gymnastics. Hypermobility may be associated more with growing pains. The next concern they have nowadays is the concern of vitamin D deficiency when they present with aches and pains like that. There is no association between vitamin D deficiency and growing pain per se. The vitamin D deficiency does not cause growing pain. The last thing I do is to reassure the parent this is something for which all that the child requires is a tender, loving care from you, maybe massage for a few minutes. The pain is very severe. You can consider giving paracetamol, and also explain to them the warning signs like swellings, fever, weight loss, unilateral pain, joint swelling, joint pain, and other warning signs like rashes when there is limb pain. And I counsel them and reassure them. This is how I approach growing pains.
Excellent. I think almost all. I can see Bala raising Baldev Bhai raising his finger. Yes, Baldev Bhai.
Actually,
Dr. Baldev Bhai.
Already it has been described, but the very specific point which I wanted to draw the attention, that which probably we should not miss. Bandage, okay, growing pain and everything. Very specifically, recently started pain, which was not there initially. And that very specific, because they will not be able to differentiate whether it's the bone pain or joint pain or so. But I think always pay the attention for the condition like leukemia. It is said that when rare, but it may be even the first sign before child develops all other manifestations. And I think it's
So
very
very well,
serious condition.
recent onset pain, bone pains at night. One must keep in mind leukemia. Sham, I can see your finger going up. Yes.
There's in a smaller child to differentiate between restless leg syndrome and your growing pain, or which is known as in today's word, the nomenclature is non-inflammatory musculoskeletal disorder, which I think rheumatologists describe. They don't want to name the word joint, growing pains. Anyway, I think it's a difference of nomenclature. We name it as growing pains only because they grow out. And see, the difference is in, you have seen movie Panga. Have you seen movie Panga, any of the panelists?
No, I have not seen.
Anyway, in this, what happens in the middle of night, Kangana Ranaut, who has been a kabaddi player and she has left kabaddi now for several years since she is married, she keeps hitting the husband with leg in the middle of sleep. And that is a classical, I think, restless leg syndrome. Okay, there's no pain associated, but in case, and the restless leg syndrome now comes after a lot of rest to the people. And the growing pain comes after a lot of exercise in the day, running around. And restless leg syndrome comes soon after going to sleep. And growing pain comes little later in the sleep. And as Dr. Prajapati was saying, if you examine the child next morning for the growing pain, joints are over, normal, absolutely normal, no examination finding. And the child just had pain in the middle of sleep. And that is what growing pain. Sometimes, although we counsel the parents, sometimes it may be so severe that you need to give maybe paracetamol in the night. But I think this is more of a placebo rather than doing something else.
Yes. Absolutely, absolutely. So that is why I titled this session as Answers You Don't Find in Textbook. There is no mention of Kangana Ranaut or Panga film in any of the textbooks. Okay. I think this we have addressed. Growing gets cramps and doctor said they are growing pains. Okay, a 2-week-old has not passed stools for 6 days. He is otherwise fine. Baldev bhai, I'm sure 6 दिन से संडास नहीं किया है.
I think
child is fine, but the parents are hassled.
Very important, very common. And I think please every pediatrician should listen, and I think we should follow. Unnecessarily don't prescribe the drugs in such patients. We know that any breastfed child, and that child even may pass the stool 8 to 10 times in a day, or even once in 6 to 7 days. But if you go in the details, that consistency is normal, child is not losing the weight or even the remain active, I think it's not diarrhea. And if you see that the child has not to strain and even the consistency is normal, I think this patient, please don't label it as a constipation and don't prescribe the unnecessary medicines, even the per-rectal suppositories. It's a normal phenomena for the breastfed child, and I think we should be very clear, nothing is to be done in this patient.
Sir, but what do you tell them? How do you explain to the parents? What do you tell them? ऐसा सर कितना दिन रुकना है? तो 7वें दिन, 8 दिन, कब तक रुकना है?
नहीं, मुझे फोन भी आता है कि आप 6 दिन बोलते थे, अभी 7 दिन हो गया, अभी 8 दिन हो गया. फिर मैं पूछता हूँ कि लास्ट टाइम कितने दिन हो? तो बोलना कि एक दफा 7 दिन भी हो तो ओके, wait for that. And I think in a due course of time they are convinced. Okay, meanwhile I will see that really it is not constipation or not missing any condition, which I will not go in the discussion because these conditions are very rare. Either the hypothyroidism or Hirschsprung or something, but that will be the real different situation. The message should be very clear. Don't unnecessarily interpret as this difficult and don't prescribe the medicines.
Yeah. So very well said, barring those few conditions, rare conditions, in otherwise normal, healthy, young infant. The hands going up. Sham, can you come in first?
Except the top
whenever there is parents describe this as constipation. कि सब 6 दिन हो गया potty नहीं किया. This is constipation to them. I think we have to explain to them constipation means hard stools. And if the child is passing stool after 6 days or 7 days, and the consistency is normal, which is likely to be normal in a breastfed child, why you want to help the child? And then they say, sir, kya farak padta hai, expository laga dete hain. I always tell them this may be okay to give you comfort because the child is not in trouble. You people are in trouble. The baby has not passed stools. But if you keep using, if you use rectal suppository, what happens is the child becomes habituated to that. then you keep on using that. So it's much better. I think counsel them if the stools are normal and the child is not keen to pass it, why you're too much worried about it?
I think I will just take a minute, Dr. Vijay. For such answers, I know that it's not so that the pediatricians are not knowing, but probably they should be convinced first. If you are convinced, you'll be able to convince the parents.
So they have to answer with conviction and with more confidence. And that is why we are collecting these pearls from you all seniors and very experienced veteran pediatricians. Jaideep, you wanted to make a point?
Formula feed might cause delayed passage of stool, and it might cause also hard stool. So formula fed baby, they often pass stool at a prolonged interval. Otherwise, what experts has told us all fine.
Right.
One must
And Dr. Bala,
remember-
Dr. Bala, you wanted to say something.
I would tell you what I do when they bring a newborn who has not passed motion, sometimes 7 days, 10 days. I take a good history, starting from meconium history, not past meconium for 48 hours or not, what type of feeding. And we must remember fundamentally, if a baby is not breastfed, the number is likely to be less. Third, whether in South India, there is a lot of practice of giving native medicines. They give what is called wasambu, which is a corrosive, and omam, etc. All those native medicines. The ayahs who come to give bath, they give those medicines. Some of them may produce constipation. Or diligently examine the ANS, genitals, and the spine and the legs for any neurological problems. And after examination, the baby's weight gain is okay, happy baby. I ask the parents, and most of the time, when the baby is constipated, there will be not only parent, there will be 2 grandparents also. I ask them, who is training more, the parents or the grandparents? Most of them, the answer will be, baby is fine, these people are straining a lot.
Okay.
Well said.
All this rightly,
So,
no medication. And I tell them, human beings are different. There may be a next baby passing 10 stools per day, breastfed, weight gain is okay, that baby is also normal. This baby is passing stools once in 10 days. Otherwise, well, no abdominal distension, do nothing. This is the way I counsel them in practice.
Yeah. So very well said, friends. Let's be a little more quick and crisp. We have done well so far. Now let's go on to the next question. He is 1 year, has only one tooth. I mean, this is yet another common problem. Delayed dentition, only one tooth, delayed interval between eruption of different set of teeth. And Baldev bhai, how do you tackle this issue?
I think regarding the delayed teething, first we should know this the normal physiology. Commonly, it is expected that the primary teeth, the teething starts usually around 6 to 9 months. Sometimes maybe early, even 3 to 4 months also. And even as late as I have seen even the 1 year or 18 months occasionally. 1 or 2 patients, even they started the teething at 18 months. But at the end of 2 and 3, I will say 2.5 to 3 years, all the 20 teeth are there. So the point is we should be aware of it. And for that reason, usually first question, whenever these parents are complaining of the delayed teething, I always ask, if you ask your parents, that is grandparents of the child, one of them even might have the delayed teething. And many times the grandmother will say, yes, my son was having the same thing. Or when the maternal grandmother is there, she will say, yes, my daughter was having the teething started there. Most of the times, like the menstrual history, even you go in the family for the teething, you will get some explanation. And that is highly convincing to the parents that, yes, it is in our family, so no problem. And really, if it is even, then before that, we should know that we should exclude these real conditions responsible for the delayed teething. All of us know maybe the rickets, which is common even in the children, particularly during that age. Occasionally, even the hypothyroidism. And very rarely, probably, before that, you may have some obvious other features like ectodermal dysplasia or so. And very rare. And if at all, if you want to exclude even the delayed teething, best method is go for the radio imaging. In the X-ray, even there will be the evidence of already the teething has started. if at all, I think very rarely I'm talking, not routinely it is required. Routinely, as I said, if these points are there, we can convince them, and probably most of the times they are convinced, and next visit they say, yes, sir, now it has started because child is irritable, putting everything in the mouth, even the more salivation, and all of us know that these are the manifestations of the thing.
Okay, barring those disorders like ectodermal dysplasia, hypothyroidism, rickets, we do come across normal children who have little delayed dentition, and as sir very rightly put it, that sometimes in families, delayed dentition, it does run in families. Jaideep, you raised your hand. Do you have anything to add?
No. It's a good.
Okay. Any other comment from any of the experts on delayed dentition? If no, let us.
I think no
Yeah.
disease is associated with delayed dentition, to be honest, unless you have a syndromic thing or ectodermal dysplasias, Down and other syndromes. Otherwise, even mild rickets is not going to hamper it. It is basically maybe the severe rickets.
So last week I had a mother talking to my clinic, and she said the lips of the child was 8 months old, they were hyperpigmented, you know, they were dark as compared to the other parts of the body. Now I tried to examine the child, elicit appropriate history, and there was nothing on the history except there was darkening of the lips. So Dr. Jaideep, have you come across such patients, and how do you tackle them?
Yeah, actually, it's usually the darkening of the nipple, even in a smaller child, less than 8 months, could be just due to the sucking at the nipples. There may be just pigmentation of the lips. And at this age, at 8 months age, number one is the pacifier use might cause the darkening of the lips also. But we must remember as a condition, Pew-Jeghers syndrome is a typical condition which may have pigmentation of the lips, but along with that, there will be pigmentation of the tongue and buccal mucosa also. So if we find the lips are hyperpigmented, then definitely we have to examine the inside the mouth. Now, though it's not in your question, but if it's an older child, then we have to think of lip biting at the pencil and pens, which are also not very uncommon practice. But in an infant, usually pacifier use, sucking at the nipples are the common cause.
So sucking blisters, though are common, you do come across pigmentation because of sucking. Anything else that any other expert would like to add? Yes, Shyam?
In these conditions, what happens if it is because of sucking, usually the inner part of the lip is involved. The outer part is generally spared. Then this is a very good indication that this is either because of repeated breastfeeding, it could be because of pacifier, it could be because of repeated bottle feeding, and the inner part becomes darker. And interestingly, this grows out over a period of time. And if it is the whole lip is darker, in that situation, you must rule out something like anemia or B12 deficiency or other pigmenting disorders. I think rare hemochromatosis and others and all that. I think mostly it is inner part of the lip, which is darker and which grows out. We can counsel the mother that this is nothing to do with any disease.
Okay. So, and then another common thing that parents come up with is the moment you try to feed the child, there is some rash seen around the perioral region. And I mean, it is not a typical long-lasting allergy. It's very short-lasting rash, but every time you feed the child and you have maculopapular erythematous rash around the mouth. So I'm sure you also must be getting such parents, such complaints. Dr. Bala, any explanation for that? And how do you answer them?
Whatever you are describing, Vijay, erythematous rashes occurring around the mouth, from the scenario you are saying, immediately after feeding, should always make me suspect food protein-induced allergy. It could well be, however, I don't know the age of the child you're mentioning. If it is a young infant, I've seen cow's milk protein allergy present with the perioral eczema, urticaria, and even anaphylaxis-like situation. The egg protein allergy, in fact, I have known mothers coming to me saying that even if there is a yellow or the white touching the skin, immediately child starts getting urticaria. Peanut allergy, food protein allergy should be high in the list. From the scenario you are describing, immediately after feeding, rashes, erythematous wheals appearing around the face, I will always think of allergy first.
A point well made, Dr. Bala. But this mother is to, I mean, I see some children where it is not typical allergic eruption which would last little long. These are short lasting sparse maculopapular lesions that appear. So I can see Dr. Sham and Dr. Baldebai also raising their hand. Dr. Bala, could you take this further, and then Dr. Sham and Dr. Baldebai?
No, it may be anything from irritant dermatitis. You know, some of these mothers use wipes with chemicals. They clean the mouth of the child and the lips of the child. That is perhaps more common.
Absolutely.
Yeah,
Yeah,
you are describing. But however benign it could be, I would definitely, what I do in such instances is ask the mother to take a video and bring it to me to make sure that it is not food proteins allergy. From the scenario you are describing, is more likely to be some chemical
contact
irritant contact dermatitis.
Absolutely. Yeah, Sham, you wanted to say something.
See, what happens is the very common situation which we come across practices, the children between the age of say 1.5 to 3-4 years, even bigger also, they keep on sucking their own lip.
Yeah.
And that leads to lipase action over that area and leads to a contact dermatitis. It is classically on the same face, and this is a much commoner situation. The child
Absolutely,
sucking on lip. And other thing which you are describing, that is more of rubbing by the mother soon after the feeding, which can lead to these, again, contact dermatitis because of friction.
Okay. Baldebai.
So I think another condition that besides these contact dermatitis, occasionally even the saliva itself, the drooling of the saliva in the child, that itself can cause the atopic dermatitis.
Oh my God, yet another question. I mean, that is not there on the slide, but my child drools excessively.
Yeah.
And child otherwise is fine. The throat examination is normal. There is no neurological abnormality. How do you tackle this problem? Anyone can take.
I think already
continue.
Because earlier I was talking regarding the drooling of saliva. We know even during the process of the teething, that may be the excessive salivation and the drooling of the saliva. That may be the physiological, nothing is to be required. But in the true sense, older child, I will say, even I will start from this very serious condition to this mild, that any child, suppose I'm entering my OPD, and child is sitting in the OPD with the neck flexion, even this continuous drooling of the saliva and fever and toxicity always rule out this retropharyngeal abscess. That is very common. I think why I'm talking to you, once a while we'll come across.
Your point is absolutely well taken. I'm talking about
otherwise commonly, I think we know that any patient with even the mental disability, even the Down syndrome, very common, even due to this teething process.
That is not like some children sweat excessively. Here you have a child who drools excessively. So any explanation that you have for that? Jaideep, Bala, Sham.
Okay.
Yeah, Bala, please go ahead.
Two things. When there is excessive drooling, I look at it physiologically due to two problems. One, it might be excessive production or decreased absorption.
Swallow.
In my OPD, if the child comes with 1 day fever and drooling today, 9 out of 10 will have either hand, foot, mouth disease or herpangina when tongue tubes are inside. Retropharyngeal, parapharyngeal is much less common. That is one.
Yes.
So whenever there is an irritative lesion in the mouth or in the pharynx, there is going to be not only increased production due to inflammation, decreased absorption because of odonophagia and dysphagia, combination of both. Two, there are children who may have swallowing dysfunction, which may be sinister, like those who have neurological problem, or those who have got upper airway resistance syndrome. Even children with massive adenotonsillar enlargement can have drooling of saliva, other than those who are mentally retarded. Last but not the least, if you give foods which are irritating, spicy foods, drooling is more likely to occur than not.
So all the points very well made. Sham, do you have anything else to add?
I
I'm
think
talking about an absolutely normal child.
very well described. This is what I wanted to tell: the nasal block, big
Okay.
tonsils, adenoids. I think this
Okay.
is can be
Okay.
one reason.
Okay.
Otherwise, an apparently normal child.
Okay. Jaideep, go ahead.
Yeah, these are all red flag
Jaideep, you want to
conditions
say?
that what we are discussing. But physiologically, it's a time for weaning. A child suddenly starting drooling, excessive drooling, and the parents are continuing with milk feeds only. So maybe once the solids are introduced, then this will get controlled.
Okay. Now, very well said, very well described. Let's move on to look at some more questions. Uh, some parents come and complain that the child has staining of the teeth, despite the child not being on medication, on any medication. Jaideep, how do you answer this question?
Well, common causes are improper cleaning of, there is no specific age, probably it's a school going child. Improper cleaning, then sometimes it's the excessive fluoride use also. Parents are using, brushing the teeth several times with a high fluoride containing toothpaste. Some tooth injury might also cause the straining, and sometimes it's the weakness of the enamels that one have to consult the dentist only, then they can only diagnose. Weak enamels also can just may just bring the part which is beneath behind the enamel, and you can see the excessive coloration of the teeth. So these are the usual conditions, I mean, what we come across.
And you just reassure them that when the child
Yeah.
gets permanent teeth, it'll all be fine.
Yeah,
And
because the child
while
is
you
not on
talked
any
about
medication,
enamel,
as you have told already.
while you talked about enamel, I mean, we also get some parents talking about brittle teeth and, enamel which is not very smooth. And they ask, doctor, please prescribe some calcium or vitamin D. Does it really help? Sham, you were raising your hand.
Yes,
You could,
yes.
yeah.
See, the commonest cause when these teeth get staining, they get damaged, they get brittle. The commonest thing in a child is caries. So caries is the number one thing. Now, what happens when the child is subjected to a lot of bottle feeding in the sleep and some sugary drink during the sleep? So what happens? These carbohydrates are there in the mouth, and the anaerobes like streptococcus mutants and other anaerobes, they react over this, they ferment this and produce a lot of lactic acid. It damages the outermost layer of the tooth, which is your enamel. So enamel gets damaged and eroded. So mothers most of the time they come and tell us, doctor, आपने iron लिखा था ना, उससे काले हो गए दांत. It is not the iron which is stained. It is that damaged portion over which the iron is sticking. So this is one. If the teeth in the front are going damaged, it's most likely a bottle caries. So they're classically damaged in the front. So this is one of the major reasons of making the teeth brittle and making the teeth stained. Second reason which comes to my mind could be if, as Dr. Jaydeep was saying, fluorosis. And other rare reason which I don't see in my practice and which should be there in a practice where there are a lot of malnourished children. So what happens that during malnutrition, there's a deficiency of vitamins, vitamin D and others. So what happens, there's a syndrome known as enamel hypoplasia. And enamel hypoplasia could be primary or secondary, and the secondary is because of these deficiencies. So once you are born with the enamel hypoplasia, you are likely to have more damaged teeth and brittle teeth. These are three things which come to my mind which can lead to staining of teeth. And then drugs, obviously, some drugs also lead to, because you said there's no drug involved. So there's some drugs also which can be involved with staining of teeth.
Dr. Baldevbhai, many parents also come and ask us, when should I start brushing the teeth of the child? Which brush, which paste? Can I use the paste that I'm using? Is there a separate paste for kids? Can you take all these questions?
Actually, I asked my one of the friend dentist to answer the really get the exact answer. And what they recommend that once the teeth is there, it has to be brushed. That means the point is from the very beginning it should be. And then the various methods he suggested. That initially even the mother can take some smooth cloth, make it wet, and even can rub over these teeth, and even it can be clean very simply. Even that can be done in 6 months, 8 months, 10 months old child. But even he said that now the older the child, older that means around even the 10 months, even the 1 year, when the fairly good number of the teeth are there, he said that the finger brush is available. And that mother can apply that finger brush over her finger. And with that, even she can clean it by using even the some pest, very minimum pest. And when you are able to train the child, and child is able to do by himself, even the very small and very soft brushes, toothbrushes are available. And very small quantity of this pest with the fluoride, that they say that even the peanut size quantity, that is minimum quantity, so that child cannot swallow. And if at all swallows, probably minimum, there is no problem, they say. And then even you can explain the child to. Second thing, child is not able to do gargles or things. So you can explain the child that just the child should spit it out after this brushing the teeth. Initially, when very small kid. And so that even the paste will not go inside, teeth will be clean. And I think when in the due course of time, child is able to manage himself, we can train the child to clean the teeth by himself. But the point is, from the very beginning, we should do it.
Yeah, absolutely. Similar advice was given by my dentist friend who says, go behind the child, use your finger to brush, use the gum massage, then brush the teeth with plain finger, then use finger brush, and then give a baby brush, and so on and so forth. So, very well explained. And now let's move on to doctor. My child is 2 years, and whatever I give him to eat, it just is passed in stool unaltered. Oh, केला खाता है, केला का केला बाहर आता है. कल रात को खिचड़ी खिलाया, सुबह संडास में खिचड़ी, राइस का दाना दिखा. I mean, I start wondering. I mean, there is such a huge, length of alimentary tract, and despite that, how come these food items are coming out unaltered? What is the explanation, and what answer do you give? Who will take this up, Dr. Bala?
Yeah.
Yes, please.
If you look at the scenario, the banana, whatever you have mentioned, watermelon, it comes out. When the first, there are three things I will do in this situation. First is, of course, in general pediatrics, the most important thing is growth and development of the child. I will look at the growth chart just to make sure that the child is not failing to thrive. And I'll ask them from when this is happening. Recently or chronically, the same thing has been happening. If it is recent, child's growth and development is normal, is unlikely to be sinister. That's one. Two, if it is chronic, failure to thrive, definitely there's something seriously wrong with the intestinal tract. But if you look at the scenario, this is not malabsorption, this is maldigestion. That is, whatever food that is ingested comes out faster. That means the motility is much, much faster than normal. I will find out if they are giving anything else which increases the motility of the intestine. But all of us must remember that all human beings are partially deficient in lactase enzyme. So it may be that the mother is giving too much of milk with sugar or too much of fruit juices along with that, which causes increased motility. By itself, a story like this, the next thing I will do is I tell them, you bring it, you parcel the stool that the child passes and come and show me like a Swiggy man tomorrow. I want to see the stool myself to make sure that I'm not missing steatorrhea, I'm not missing serious malabsorption. And of course, I would examine the abdomen for distension, perianal excoriation, and other signs of malabsorption. In most such instances, when parents come with a history, it is benign rather than sinister. And this often occurs during toddlers, more often following an acute illness like diarrhea.
Okay. Now, here at this point itself, let me ask you, some parents also would come, उल्टी करता है तो वैसे के वैसे, और कल रात को दाल चावल खाया था, आज बाहर निकला. So, Sham, do you come across such parents and such questions in your practice?
I think first part very well described by Dr. Bala, that if the child is not having diarrhea and the child is not having oily stools and growing well, I tell them this is a 6 feet, 7 feet long intestine. Don't worry. And they have a more intestinal hurry. and something gets passed out, and that's quite okay. So don't worry. The growth is okay and the motions are not watery, and two, they are not oily. Now coming to the second part, that कुछ भी खिलाते हैं तो ये vomit करता है. I think that here the problem lies with the mother, not with the child. Such babies are subjected to force feeding without appetite. So what they do is the father is dancing and the mother is feeding the child. So he's watching the dance and being fed. The child is made to see a TV where some music or something is going on, people are dancing, and he is made to fed. So see, let the child appetite be there for eating first. I think the first thing is to let the child have hunger and then feed the child. I think this is more of a problem with the mother. They force feed it, and once the child takes, sir, force feeding नहीं करते, ये तो खुद खाता है. अब ये नहीं बताते खुद कैसे खाता है.
And ऊपर से बोलते हैं कुछ खाता नहीं ऊपर से.
That's the reason कुछ नहीं खाता, because you are subjecting the child to force feeding. You are not calculating his snacks per day, which is having good quantity of calories, and you are just calculating roti kitni khai, dal kitni khai, or chawal kitna khai.
Absolutely.
So this
I
is
can
the
see
problem.
Baldev bhai's hand going up. Baldev bhai, you raised your finger.
The only one point I wanted to add, that when the particular child is passing the pieces of the food in the stool, probably besides, yes, the hurry intestine is the major problem. But another thing which I have found, that the child is not chewing it properly. Even the whatever the pieces, once we train the child that you chew at least for certain time, I'm sure that so two problems are there: not chewing properly and hurry of the
Intestinal hurry. Yeah. Okay. So let us be more. There are a lot many questions left. And this mother came and said that there are complaints from the school teacher that he keeps biting other children in the school, or from other parents he bites his playmates, or he bites his sib. And this kind of habit of biting others, how do you tackle this? Jaideep, would you like to take this?
Yeah. Actually, it's a more sort of an exploration for the child. I mean, he wants to see that what happens when I bite. It's satisfying the need for some odomotor stimulation, and it's the imitating some children or adults. There is a strong, feeling of strength and control of the situation by biting others. That somebody is having pain, trying to get attention. Often, it's a self-defense also. Child in the school might be of a bigger size, and he beats this child, and he cannot protect himself. To protect himself, just as a self-defense, he bites. In some children, when it's at the home also, it's a communication, it's a sort of communication for some needs or desires also. And sometimes there is anger, fear, a confusion that the child bites his parents. And sometimes in infant, it's also for relief the pain, for teething pain. But more often when it's in the school, it's just an exploration that what happens if I bite, and then just to establish the authority over his ear.
Jaideep, very well answered. As an extension to this, the other day I have a mother coming to my clinic. Said, I got a complaint from the school that my child keeps biting at the collar or the tie that he wears in the school uniform.
Yeah.
So what could be the reason for that, and how do you answer them, and how do you manage such complaints?
See, this biting of the garments, the collars, the ties is an effort maybe to just, it helps in concentration. In previous times, people used to chew at the tobacco or chew at the pipe. The philosophers, you have that impression they are chewing the pipe and then writing. It helps in concentration. So it's also a manifestation, like chewing the collars, chewing the tie, just to have that concentration. And also it might be a lack of physical activity also. The child always wants to move here and there. And when he's sitting at one place and trying to study, it might be a manifestation of some physical activity also. Of course, on the other side, we must be aware of the anxiety disorder, the autism, ADHD, and other sensory problems. Those are at the other spectrum, at the other end of the spectrum of this condition. But more often or not, it's just a way for concentration, and sometimes it's also sort of jaw muscle exercise when the child is not given some food to chew. It's always given liquid or semi-solid food. So the jaw muscle also needs some stimulation. So the child takes the collar of the shirt and bites it. So these are the usual situations.
Fine, Jaydeep, but what is the remedy? What do you tell the parents? How to overcome this?
Well, the remedy, see, applying something bitter or tying those things or holding the hand won't really work.
Absolutely.
Won't really work. The child will find some way out. Just you know that they have this tendency. But only thing is that they should be counseled. If it's anxiety, if it's the concentration that is needed, then they should be counseled. And the mother is most often the best counselor. She can counsel that yes, you can do without it. You can do it without it. You are damaging your shirt. Your shirt is so nice. We brought it. Sometimes some sort of counseling, and the child can be calmed. And of course, the thing that I was telling, the lack of physical activity. The child should be allowed to play, then come back, then study, something like that. So it's the simple counseling and the simple methods that the parents can adopt usually solve.
Okay. Baldev bhai, quickly,
Yes,
have you all realized that we have spent more than an hour discussing this?
Yes.
But
Dr.
very
Vijay,
well, the time is flying. But yes, Baldev bhai, go ahead.
Which I recollect from this one of our common PG session by the child psychiatrist. Two things just I would like to make for the chewing this collar of the shirt. They say that either these, very nicely Dr. Jaydeep explained, that either they require some concentration, thinking or something. But another aspect which is very common in the children is when they feel the embarrass or there is a shyness. Probably this is for the release of these emotions. Very commonly they are doing like this. In the shy children, on the contrary, they say this is very common. Or when particularly the teacher is scolding or something, child is embarrassed. I think this is very common observation with this group of the children. And then probably we can manage with this help of the psychiatrist.
Does insecurity also play a role in
Yes.
children feeling little insecure?
Yeah,
That also, I believe, must be playing some
Yes.
role. Okay, now let's do some rapid fire. Sita, we have answered this. Nails are not growing. I don't remember having trimmed the nails in last 4 months. Any one of you can take this quickly. Nails not growing at a pace they should grow. Sham?
I think it is more to do with the wear down while playing and more to do with I think biting, nail biting the child may be doing. Otherwise, just have a look of the nails. There are few conditions where the nails look a little abnormal. There are few conditions which can block the growth for some time. For example, post your hand foot mouth disease. So they can be blocked for 2-3 months. Otherwise, I think nail growth is quite okay if the child is growing otherwise well, and the nails look they look okay. I think I won't worry too much. I think sometimes the parents give too much importance to these small things, and the child is okay. The nails look okay.
That this has been my observation that a lot of children with atopic dermatitis, they have little retarded growth of nail. What is your observation? Maybe indirectly because they keep scratching, and that could be the reason.
I think if you keep scratching, and if there's a while playing, there's a wear down, or there's a just nail biting, all those factors lead to nail being labeled as not growing.
Not growing well. Yeah. So next we have my child's teacher scolded because we have addressed this. My son often says he has pain in the head lasting for a few seconds. It comes and goes. So otherwise child is absolutely fine. No other significant history. And it really bothers the parents. They are worried. CT scan karwa lu kya, MRI karwa lu kya. Dr. Bala, how do you tackle these children?
This is a frequent problem. Because it boils down to good history taking whenever any child is brought with headache. But more often, than not. These momentary headaches coming once in a while is mostly due to stress or anxiety than due to physical disease. Having said that, I would look for a few red flags in the history and physical examination. The red flags include a family history of a stroke or a hemorrhage. I would definitely take. And family history of some renal cystic disease, in which case there is a strong possibility there may be an AVM. But I have at least had an experience of a pediatrician child who had headache just like that for two days, minor headache, ultimately fell unconscious, AV malformation, bleed. I mean, these are all stories which we hear uncommonly that makes us worry about the possibility of a sinister cause. At the same time, there are some red flags we must remember. One, if the headache is disturbing the activity or the sleep, and the headache is progressively worsening, and if the headache is associated with some visual disturbances, transiently or persistently, and if the headache is associated with disturbance in behavior, school performance, sleep, associated with vomiting, comes in the mornings, disturbs the night sleep, definitely I'd be wary. But at the same time, your scenario of a headache coming for a few seconds, just like that disappearing in an otherwise well child, I will do a complete growth and development, examine the fundus in my clinic, check the blood pressures, and definitely, now all our children don't undergo periodic ophthalmologic examination. I would definitely tell them, not because I want to rule out papilledema, I will ask them to go for a routine optical checkup, and it reassures them. Family history of migraine is very, very important. And more often than not, such transient headaches are non-organic. I reassure, counsel them the warning signs, ask them to come back if it worsens or persists. This is what I do.
Absolutely well explained. I can't think of any other answer to this. Yes, Baldev bhai, you have anything to add?
Only one, I would say, patient or experience I would like to quote. I remember 15 years back, 10 years old child having this type of a headache for a very short time, and then child all right. Consulted by even the neurologist, psychiatrist, considered migraine, everything. I remember that ultimately turned out to be the pheochromocytoma. And that time, in between, the patient was absolutely fine. So I think very rare, but I think then this is a scenario, and we know that nobody bothered to measure the blood pressure. But the pheochromocytoma is known to present in this way.
Well, point well taken. We do get, bowled by once in a way such anecdotal or uncommon, very rare cases. But as Dr. Bala said, by and large, this momentarily occurring headache, if you have elicited detailed history and ruled out those red flag signs, one need not really worry about them.
Yes, yes.
The next question that I have on my screen is, can I give cod liver oil to boost the immunity of the child? Yeah, Jaideep, do you advocate cod liver oil? Yes.
Not really. I think.
Okay.
I do come across such queries. What I tell that see, immunity is something which is innate. Nothing can. There are so many products available everywhere. So nothing can really boost immunity. So that's why.
Okay.
I think whatever may be the reason, but some of the teachers used to prescribe it.
Then there is a misconception amongst parents that milk leads to cough or phlegm formation. So what is the explanation why this myth is around in all mothers' minds, and how do you tackle it? Who would like to take this quickly? Baldev bhai, bolo.
Exactly reason I don't know, but how I explain to them. अभी आप milk देती तो नहीं हो, उन्होंने बोला कि नहीं देती हो, फिर भी cough तो है, तो milk से है तो वो cough चला चलिए. That means milk is not responsible for the cough, and very simply they accept.
Yeah. Shyam has something to add.
I think I use this opportunity to stop bottle. I tell them the milk is not the culprit; it is the bottle.
Maybe.
And there's a data to show the babies who are on bottle feed, they may have micro aspirations and more respiratory infections. So you save the teeth, you save the respiratory infections, and don't blame the milk. And I always tell them milk is not a problem, it is basically the bottle. So I think I used this opportunity, as Dr. Bala used in the last case, where there's a headache, use that opportunity for eye examination. I don't think it's related, headache is related to eye, but use that opportunity for eye examination.
Jaideep, is Odomos safe? Can Odomos repellent be used on the skin of a child?
Yeah, well, the classical Odomos that's available contained a chemical which is DEB, diethyl benzamide. Now, diethyl benzamide is more or less safe for the skin, but sometimes in some patients it may cause some skin irritation, and rarely, very rarely, it's associated with seizure disorder also. But at present, the Odomos, there is one more variety, which is the natural Odomos. It contains citronella oil mainly, along with other, which is a natural product. So probably this Odomos natural is quite safe for the skin, and the Odomos with DEB, other than skin irritation, well, if the child has tolerated even a small amount, we can apply in the food. If it's tolerated, then it can be applied. And Odomos natural is more or less safe for skin.
Okay, so as a general principle, it is better to know the content of the application, whosoever, I mean, whatever question the parents have, it is always better to know the contents and then comment on it. Okay, now many parents come saying that the child squats in a W kind of posture. Not an uncommon thing at all. Dr. Sham, how do you tackle this? Do you really get worried about this? Do you really aggressively
Yes,
counsel against this?
I think many children do this while playing, and this is quite okay. Nothing to worry. Child is persistently on this position and doesn't prefer any other position, then there's a bit of a concern. See what happens. What happens in W position, it makes the child a little more stable. And because you are expanding the area of spread where the child is sitting, and then the center of gravity also goes down. So this is a physiological thing where the child becomes stable, and the side to side movements are a bit restricted, and the child can play state. So this position, if the child is persistently interested in this, I'll be worried ki, does he have some soft neurological signs or all that, because he's not stable in other positions. This is one. And secondly, if the child has got congenital dislocation of hip and all that and is doing this position, so then you are doing a lot of internal rotation. And by doing a lot of internal rotation, you can dislocate the hip. So these are two issues which come to my mind. If the child otherwise is running around, is stable, and he sometimes prefers this position, I'm not bothered about it. But many, sometimes a mother says, sir, ये और किसी position में बैठता ही नहीं है. So then needs a little more detailed examination.
But you're not worried about this leading to any deformity as such.
I don't think this is the only thing, because you are doing extreme internal rotation. In that situation, you can dislocate the, particularly at a younger age, not after the age of 4 or 5 years.
They say that if it continues beyond the age of 2 years, then the possibility of these deformities and instability will occur.
Okay, Dr. Bala, what brain tonic do you prescribe to mothers who say, my child does not remember anything, he keeps forgetting, and child otherwise is normal, has no obvious, signs of mental retardation or hyperactivity?
The only brain tonic which may help somebody with
Badam.
memory, including me, is perhaps only iron. Studies have shown that if young infants and children suffer from iron deficiency anemia, their intellectual potential in future itself is reduced. Because iron, as we all know, the first response to iron therapy is improvement in the behavior of the child. It is not by improvement in the hemoglobin, it is by replacement of cytochrome oxidase enzymes in the brain, for which mono inhibitors, etc., which require iron as co-actors for the brain function. So if at all anything is going to help somebody with poor school performance, it is only iron. And we must also remember 40 to 60% of Indian children do have iron deficiency anemia. And somebody like me, a pure vegetarian, is more at risk of developing iron deficiency anemia. And young infants and toddlers who are given on one extreme, either given, not given milk because of fear of LRA, or given 1 liter of milk in a bottle because they think milk is nutritious, child is not taking feeds, bottle fed child, definitely that child will suffer from iron deficiency anemia. If the child has features of anemia, definitely iron supplementation would help. But if the child is otherwise normal, I will reassure them and not do anything about it. But at the same time, I would inquire again into the history. If the memory loss is progressive, then my antenna goes up. I'll start thinking of sinister neurological conditions, starting from SSPE to Wilson's disease.
A very valid point made. Delayed weaning, excess milk, and a lot of children we do see, especially infants and young children, coming with iron deficiency, and that factor has to be kept in. I have a question coming from one of our delegates. He is asking, some infants take feed when they are asleep, and some mothers find it more convenient. How should you handle this? Should the mother be allowed to feed in sleeping position, and are there any harm in this kind of practices? Yeah, Sham?
Coming back to the last question, where what is that? Iron. What is that?
Brain tonic. Child keeps forgetting whatever is taught.
Dr. Bala was
normal.
brain tonic.
Brain tonic.
I think many of the time mother unnecessarily is bothered about the memory. Most of the time the mother is unnecessarily bothered about the memory. For example, if you tell them कि तुमने जो बच्चे को कल कहानी सुनाई थी वो आज सुना सकता है, कहती हाँ सुना सकता है, सर पढ़ता नहीं. So they take it as a memory is not good. Yeah. So I think the commoner thing is the child is okay otherwise. In our practice, there's hardly any anemia. So in these conditions where the child are well fed and they belong to higher socioeconomic class, so most of the time what happens is that their memory badi kamjor hai, padhta nahi hai. So and when you ask them these questions, their memory is quite okay. सर उसमें तो ठीक है, अदरवाइज नहीं है ठीक. कहानी सुन दो सर, इसने एक हफ्ता पहले पिक्चर सुन देखी थी, पूरी कहानी आपको सुना देगा. So take it like that, and then I think there are a lot of things in pediatric. I think. Yeah. Current question is that. What is that?
The second question is somebody is asked. Dr. Manocha is asking. The baby prefers feeding in lying down position, and mother is also comfortable. So, is there any harm in this kind of a practice?
Lying down bottle, yeah, this thing, food.
Bottle feeding, both. Breastfeeding?
I think it is dangerous as far as solid food is concerned to make him feed during lying down position. That can be dangerous. And secondly, making the child sleep with breastfeeding and that. I think after the age of 1 year, you should avoid that. The reason I told you, I'm going to damage the teeth. I think mother should just wait. The child will have appetite. Don't give him snacks and all that. The child will eat in the day. There's no worry about it.
And Baldev bhai, many mothers come saying that the child is addicted to the breast. Pure raat bhar use muh mein chahiye. So how do you tackle this? How do you counsel such a mother?
I think that depends upon the age. What addiction you said, I think that may be the older.
Say maybe say 1.5-year-old child, 18-month-old.
Then it is probably more of the addiction. But initially, many times it happens so that the child is more active during the night time. In the initial phase, I would say early infancy, 6 months or so, and therefore taking the more feeding during the night time, less of the during the daytime. And I think nothing is there, and the cycle is going to be changed. But as you said, in the older child, if it continues, we know that rather than the 1.5 or 2 years, child is continually sucking the breast during the night time. Probably it is not for the sake of the milk or not for the sake of the feed. Probably that is the child feels the insecurity, and with the presence of the mother, because the breast is in his mouth, maybe feels secure. So I think that it's more of the, rather than the nutritional or feeding problem, this is more of this behavior problem also. And that's what I will say, if you start this weaning, what we say, complementary feeds in time, 6 months, and gradually train the child, 1.5-2 years, I will the child is eating the family diet and gradually away from the breast, probably this problem may not develop. So okay. I think it's a proper weaning is required.
Jaideep, I have a question that some mothers complain that the baby feeds only on one breast. It just doesn't latch on the other breast. How do you tackle this problem? And there
Yeah,
is no inverted nipple, no retracted nipple, nothing. You examine the breast and both breasts are normal.
Yeah, in small infants, sometimes they are comfortable in one position. That means, say, they were having that particular posture inside in utero. They prefer that type of posture when they are outside also. So sometimes they take the left breast mainly, and they do not want to go to the other side. This is usually a phased manner. So if the mother tries somehow, and if the mother just takes time to get the child, get the baby adjusted to the other side, usually they can overcome. But other than that, see, unequal milk flow in two breasts is not that common, and it's not usual also. So it's usually the practice and the motivation of the mother with some patience. If she tries, usually this can be overcome.
Very true. In some patient, what I tried, if the mother is, the baby is coming feeding in the left breast, just slide the baby across in the same position and support the baby and ask the baby to feed
Right.
on the other breast side. It works. Sham was raising his hand. Sham, acha, you wanted to say the same thing. Baldev bhai?
The only thing, it's a problem of the position of the tactic. So that is to be solved.
Absolutely. Absolutely. So Dr. Indu Khosla has a very interesting comment. I can read it on my screen. Nail biting or thumb sucking have been implicated as a habit for self-gratification. Two schools of thoughts: leave it, will pass, or restrict it. My thought, it is easier to get rid of it if tackled earlier. Your comments on this. Dr. Bala, would you like to take this? Yeah.
Yeah, I will quote Illingworth, who said, what the parents do about thumb sucking is more harmful than thumb sucking itself.
So that will leave it alone, leave the child alone.
That is one. Two, there are studies which have shown that young infants and toddlers who have problematic thumb sucking, they are emotionally more stable than controls. Two.
Okay.
Three, there have been studies linking thumb sucking to future smoking. I believe those who have thumb sucking in young age have been known to become smokers as they grow old as adults. These are all interesting information available in the literature.
Yeah.
But having
Yeah.
said that, thumb sucking is more of a bother for the parent. We have to counsel them and talk about good child rearing practices and try to move the attention away from of the child. Attention of the child away from the thumb to other activities in life. If the modern day parents, they show only mobile phones, and the baby is happy putting the thumb into the mouth and watching all sorts of cartoons and movies and songs.
Yeah.
There is no other way. What else will the child do other than suck the thumb? There is no stimulation for the baby. That is what we should attend to rather than do anything to try to stop to thumb sucking, which is much more difficult than any other serious disease in terms of treatment.
We close in 2 minutes. I'll take two quick questions. Baldev bhai, one of the parents came and told me that my child passes passes gas every now and then, and it stinks very, very foul. What is the explanation? How do you tackle this?
I
Quickly.
think one should go in the details, and I'm sure that you will get this constipation as a problem. I'm sure that most of the times it is a constipation. And if you go in the
Okay.
details, try to locate any cause. If it is a functional constipation, most of the times that is the reason. Then probably the proper advice, very specifically regarding the diet, which contains high fiber diet, and most of the management of the constipation, I may not get the details, but the
Fine.
point probably indicates the chronic constipation.
Does high protein give rise to stinky gas or fart?
Possible.
Okay. And Sham, one last question before we close, because it's already 3:30. Prem, I think we have to close at 3:30. Yes. And of course, we need to give some tea break to our viewers because they have to come back for the IAP webinar, which starts at 4 o'clock. Sham, the other day I had a parent walking into my clinic and says, a 5-year-old child. And the parents were very worried and they were a little hesitant in asking the question. And finally, they said, they asked my assistant to leave my cabin, and they said, I've never seen my child having any erection. Is it of a concern? Should I take him to an endocrine hormone specialist? He was saying.
I think I have faced this question 3-4 times. Childhood masturbation at the age of 2-3 years. and this question that the baby never had erection. So these two questions I faced in my practice, and I have, because the first patient was labeled as seizure disorder. He came from Haridwar. And the second, this one was, which I went into detail. In fact, to be honest, when the child came to me about 15, 20 years ago with this, I didn't know the answer, in fact. I searched the literature then, what is this question? And I examined the child in detail. Child is normal, testes are okay, penile length is okay for that age. Child otherwise is growing normal. And the father tells this is about 80-year-old child. This is kabhi aaj tak I have not seen the penile erection. So I have searched literature several times. And in fact, we have discussed this in our one of the meeting in Max also. See, answer to this is very tough. People have not been able to answer this properly. But I have searched the literature on this some time ago. And the literature is something like this, very interesting. It is like this: when animals were given high dose of catecholamines, they do not have erection. So this started from animals. So come to the adults, young adults, those who are anxious, those who are depressed, or those who have stressful life, they have erectile dysfunction. This is proven. So it is believed that there's a sympathetic outflow, which is causing it. Is it to do with sympathetic outflow of these babies? That is a question mark, and most possibly appears to be the answer. Most possibly these children have more of a sympathetic outflow, and most of them grow out. So I think this is how I counsel them. And to my mind, this is the most appropriate answer I could search, because I've searched this incidentally. Rest of the questions we have not searched too much. And this appears. Anyone else? I think Dr. Bala can comment on this if he has any answer for that.
Bala, you have any other explanation?
A very difficult problem to handle. But having said that, see, the other extreme, priapism is sinister. If there is persistent priapism, and
Yes.
I have seen that happen in scorpion sting. I have seen at least one child who had leukemia who presented with
Leukemia, sickle,
leukemia.
Sickle cell.
Sickle cell can also be
Yeah,
arrested.
sickle cell that
snake
can.
bite.
But and I have come across a few parents coming and telling me 6-year-old, 5-year-old boy trying to misbehave with the mother with an erection. It's an erection. But most of the time, if you don't find, of course, I would check the BP, because I would definitely think of something, some hormonal dysfunction. The child is otherwise okay. I counsel the family rather than do aggressive investigations.
Well, okay. Thank you very much, Dr. Sham. That was a brilliant, answer, and thanks for searching literature and coming out with a definite answer for this. Well, friends, we spent almost 92 minutes discussing these common issues in our practice, and I have a lot of queries from the viewers. And perhaps they thought that when we announced the webinar as answers you don't find in textbook, they thought that we'll be coming out with answers with respect to COVID. But if Prem allows, we can have yet another session on COVID and leave all those questions for COVID session. But I have tried to address some queries that were flashed on my screen. And thank you so much, my dear friends, Dr. Jaideep, Dr. Baldev Prajapati, Dr. Balasubramanian, and Dr. Sham Kukreja. You have been excellent. And I'm sure with the wisdom that you have shared with the viewers, they would be definitely more comfortable and more well-equipped to answer such questions that they come across in practice. And my apologies to the viewers if I have been unable to take all the questions. Well, thank you very much. Prem, if you permit, can we close this session and sign off?
No problem, sir. Thank you very much, sir. Thank you
Yeah.
all the faculty members. And thank you very much for this learning session. Definitely all the viewers like the questions, sir. We got over 83 questions.
I
till
hope the
now.
viewers.
Yes.
Okay.
And we are getting good feedback also, sir. Feedback also will share with you. Definitely. Thank you very much, sir.
Thank you. Thanks a lot.
Prem, what I would suggest is if you can send those questions to us in writing, we would maybe prepare a small booklet, FAQs,
Sir,
answers
exactly,
not
sir.
found in textbook.
Yes, exactly. That's what we
Then
were
you
thinking,
can,
sir.
Yeah, you can.
True, sir.
Yeah. So get all those questions. I'll have my expert friends answer them, and we'll come out with a booklet on answers you don't find in textbook.
So that would be fantastic idea, sir, actually.
Definitely, sir, we'll do that. Definitely.
So thank you once again, and thank you to all my
Thank you, sir.
experts. Thank
Thank
you.
you, sir. Thank
Goodbye.
you,
Thank
all
you,
the
sir.
viewers. Thank you.
Kumidira, let's
Thank-
say
Bye, sir.
goodbye.
Thank you.
Thank you. Thank you
you.
so much.
Thank you.